So it's such a pleasure to see so many old faces and new faces, and I just really want to introduce or welcome everybody to Denver for this conference. These conferences happen, every couple of years, and in between each time they happen, we meet a bunch of new families and new research happens, and some old long-standing issues continue to be long-standing issues or concerns. And so these conferences for me are a really nice way to kind of reframe kind of where the field is, where we are in patient care, where we are in advocacy and national support for all the conditions. And it's a really also a great time to catch up with people and to see people. I've been working with X and Y variations, and you guys will hear a little bit more about this in my talk, since 2007. No, 2004 was the first year. And so now it's been a long time. And some of these guys and families in the audience I've known since that time. And so watching these guys who were tall then become even taller, and some of the families grow up has been a blessing, and I'm just very enthusiastic about having everyone here. Okay, so today Sharron and I are going to really try and introduce some of the current research and hot topics and important new directions that are happening in the field. And a lot of times at the beginning of these conferences, I've been asked to do a presentation of, what are the top 10 research findings over the last, 2 years or, that have happened recently. And I feel like I jump into these slides of lots of science and details and new things, and it's always felt kind of overwhelming to me. I just wanted to think about kind of what the big picture is, right? And so when we're talking and working with families and thinking about just advancing this field, what is really the kind of the big picture in terms of, what we need to do, what happens with families, what all the steps are. And so, when I was thinking, this is really kind of, a lot of the important steps. The first step is getting a diagnosis. The second step is you moving that diagnosis to treatment. Obviously, the family and the patient is involved in this whole process, and the ideas and the needs of the family and the patient should be at the center of what drives and changes these things. And then this process underneath needs to circle back in terms of improving all of this, right? We need to do research. We need to hear from people. We need to improve care. We need to do all these things. And this process has to keep going to get better and better and better so that we can all do a better job taking care of our patients, and then also so families and patients have better and better experiences throughout their education and their life and their just, overall quality of life. The diagnosis itself seems like, if you think about a lot of conditions, oh yeah, of course, you get the diagnosis. For many of you in the audience, it's not just that simple, right? Many people in this audience have been through a huge odyssey and turmoil and a lot of time and concerns and a lot of appointments before they even received a diagnosis. And so, this is something that just getting to the diagnosis for many has been a big area of challenge. And then once the diagnosis has been made, the next question is, what do we do about it? But I want to talk about a little bit more about, some of the research and the advances in terms of diagnosis recently, because I think this is one area to me where things are changing rapidly, and where I think there's going to, really be the changes in diagnosis is going to be very important in terms of moving the field forward, not just for medical care, but also for public awareness and for all the challenges that people have experienced in the past in terms of even having people be aware of the diagnosis and know what it is when you go in to a doctor's office or to a school system or to, talk about it with somebody who is supposed to be providing support to you. As many of you guys may have heard, but some may not be aware, there's a new method of diagnosis. In the past, there were always, the diagnosis of X and Y variations is typically made by a blood test. And that's a blood test on the individual who you're testing for to look at their DNA and check their chromosomes and see what the differences are. So in the past, this was one of the primary ways of diagnosis, was that someone has a suspicion of the variation and they do the blood test. And then eventually it's diagnosed. There were also prenatal diagnoses. So in some women, before they were pregnant, there were either signs within the pregnancy that there might be a concern based on some of the testing or screening or ultrasounds, or sometimes for advanced maternal age, there would be genetic testing offered. And then in the past, there would have to be procedures done where the OBGYN would go into the more invasively with a needle and collect either amniotic fluid or sample from the developing baby to diagnose the condition prenatally. And so we would have a small handful of patients who were diagnosed in the prenatal period, whose families knew about their diagnosis before birth, but the majority of patients were diagnosed after birth upon presentation of different symptoms or concerns along the lifespan. And this new technology, it's really been many, many years since the discovery was made, but it was discovered that in a pregnant mom's blood, there's actually a little bit of the baby's DNA that transfers through the placenta and floats around in the mom's bloodstream. And so by testing mom's blood, you can actually do genetic testing on the baby. And so this is a new, you can do genetic screening on the baby. Right, so you can identify fragments of the DNA in the baby, and then be able to identify if there's differences in their genetics that are important. This is really important because it can be done very early in the pregnancy, and also doesn't include many of the risks of the amniocentesis or CVS testing that used to be the way to obtain prenatal testing. And so this technology and these advances are very important in terms of the number of patients, pregnant moms who are willing to have prenatal testing, and because they say, or prenatal screening, genetic screening. The reason there's an important differentiation between screening and testing is because when the blood test from mom comes back, it is definitely not a definitive diagnosis in the child. It has to be followed up either by amniocentesis or by postnatal testing of the baby's blood to really confirm that abnormality is there, because there are false positives and false negatives, but there's definitely a high false positive rate that needs to be confirmed afterwards. So it's not a definitive diagnosis when there is a positive screening test. It still needs to be confirmed. So that's just really important a lot of times in terms of making sure families understand when there is a positive test, it is it still needs to be confirmed to make the true diagnosis. But this has been really important because it really changes kind of how prenatal testing is done prenatal screening is done in the OBGYN field, and it leads to a much higher rate of identification of X and Y variations than in the past. In the past, there was a small segment, like I said, that were prenatally identified, and then a big piece that were identified after birth, but the majority of individuals with X and Y variations were still not diagnosed through the lifetime. And depending on if it's XXY, it was estimated, 70% are never diagnosed in their lifetime. Triple X and XYY, it's likely that 90% are not diagnosed in their lifetime. So, while we know these conditions are very common, the diagnostic odyssey that many of you in this room have gone on to is because there's really people are not testing or aware or seeing the symptoms in order to do the testing. So the formal, technical language for the, testing of mom's blood and finding the fetal DNA in maternal blood is called non-invasive prenatal screening. That's the NIPT is what it used to be called. NIPS is what it's called now. And in May of 2016, the American College of Obstetrics and Gynecology expanded their recommendations of this to say it should be something that should be offered in all pregnancies. So at the beginning of the test the screening being available, it was only being used kind of experimentally, and then it was being used in high-risk pregnancies, and then it was found, we really support this as one of the options for prenatal screening for all pregnancies. And so this is a big deal because it definitely leads to the potential for all cases, or many cases, of all of our X and Y variations being diagnosed. This is a slide that really gives us kind of an estimation of, the current diagnosis rates in XXX or XYY. And so in general, like I was saying before, a big chunk of patients go through life undiagnosed. Not without symptoms, but without somebody doing the test to be able to identify the condition. A small piece are diagnosed prenatally, a small piece are diagnosed in childhood due to developmental delays, a small piece are diagnosed in adolescence, also due to maybe neurodevelopmental problems or other medical features, and then a small piece in adulthood. But this is a very small piece of all of XXX and XYY. In XY, or Klinefelter syndrome, it's a little bit of a bigger chunk because there are physical features related to the infertility and the testosterone deficiency that sometimes lead to testing and identification, and also related to fertility then in adulthood, which is when some of the individuals are diagnosed. But it's still in XXY, or Klinefelter syndrome, it's still about 25% to 35% that are diagnosed in their lifetime. If we think about changing this little prenatal sliver from the 5% it is now to identifying almost all of those cases, then that is a big change in terms of the number that are diagnosed. And so, thinking about what this impact is of this non-invasive prenatal screening, there are 4 million babies born each year in the United States overall. If we think that 1 in 400 of those babies has a sex chromosome abnormality or variation, then that means there's 10,000 newborns with X and Y variations that are born each year in the United States. Right now, if we pick up about 10% of those in this early childhood period, maybe 5% prenatally, 5% in childhood, that leads to 1,000 infants per year being diagnosed, or maybe 5,000 babies in 5 years. That's still a lot of babies, and there's still, a lack of that next step in terms of what do we do with all these babies that we need to work on. But this is, only 5,000 babies in 5 years. If you think that we're going to change that to 75%, which is, not every single patient is always going to have the screening and be identified, but a big chunk would, then that's 7,500 infants per year, 37,000 babies in 5 years in the United States. So thinking back to, especially those who had a prenatal diagnosis a long time ago or who had young kids, the amount of support and information and knowledge out there about X and Y variations when you went into the doctors to try and figure out what to do with this diagnosis, in the past it was really poor, and part of that is because the diagnosis wasn't being made as commonly as it should have been. But, when doctors and counselors and others aren't aware of the diagnosis, then it's hard for them to learn about it and know what to do, right? And so with this new screening, I think it's important, definitely, for all these new infants who are being diagnosed, but I think it's going to really change and be very positive for everyone, even those already diagnosed with X and Y variations, because it's going to increase awareness. And we have to, we have a lot of work to do to educate counselors and educate teachers and educate the physicians. But if it keeps coming up, those people become much, much more motivated to learn and to want to help and to want to be able to understand how to work with these kids and these adults specifically. And so, I think that this is just going to be a really positive change, and I'm very supportive of the use of this screening, because I really feel it's going to help a lot of people, grow up and have more successful and productive lives, and fewer challenges along the way. So that's a little bit about diagnosis. And then I think there's also a lot, going on when we think about this transition to treatment, right? this little arrow for some people getting to treatment is also a big challenge, right? This arrow for some, okay, I have the diagnosis, now what? And then being able to implement and obtain and access all of those different treatments is challenging. Sometimes there's no arrow. People say, no one knows what to do, no one knows how to help us. Sometimes, oh, we got partially a little arrow. Sometimes people get backwards arrows and they go the wrong direction. Or people have had experiences where they get, maybe some arrows going forward, but otherwise, a lot of different directions in terms of care. And so this arrow, while it seems insignificant, has been a big challenge as well in the past. I want to talk a little bit about the development of our clinic and about how I feel like this arrow is also in a place where it's changing a lot. This is me back in 2004 in the mountains of Colorado at my first XXYY family retreat. And so my job at that time was to describe XXYY syndrome. I was a fellow in developmental pediatrics, and the research grant that we obtained was to do a study to differentiate XXYY from XXY and the other variations, and to really well describe this group. So I sat in the mountains for those 3 days in a little tiny bunk room, just taking notes and listening to families. And, okay, tell me about the medical, and I was thinking I was going up there to get, okay, I'm going to find out how many kids have seizures, how many kids have had learning problems, how many kids have had behaviors. But it became very clear that that wasn't the story that families were telling. So the story families were telling were the challenges of diagnosis, the challenges of people understanding their kids, the challenges of finding someone who they did not have to teach about their kid's diagnosis to be able to receive treatment. And the challenges of being, how come I'm the expert on this? I want someone else to tell me what to do about my child instead of the other way around. And I met all these really cool, awesome guys. Are any of them here who are in this picture? Yeah. So these guys have been my friends and have taught me and really directed me into what's important to them. And so, this was a really important and kind of, very inspirational time in terms of realizing, wow, there is a lot of work to do in this field. There are not very many people doing it, and these families really need help and support, and these guys, and later on when I added the Trisomy X group, the girls, are really awesome, cool, and fun kids who have a lot of awesome strengths in addition to some of the challenges. So this is a really complicated slide, but basically in talking with families and then working, like I said later on, with many other families with XXY and XXX and XYY and other variations, this is what they told me they needed. So, they needed some coordinated care where the endocrinologist talked to the psychologist. They needed a social worker. They needed someone to help with their motor skills and occupational therapy. They needed the speech therapist to be able to talk to the occupational therapist and to the other people. They needed genetic counseling. So basically I said, okay, well, let's build a clinic. Clearly this is needed, and so we got to think of all the different components that are going to be needed as part of this clinic. And then, in addition to all of these specialties, they needed someone thinking about it all in one piece, right? Let's think about my whole child, not just piece out, okay, education's over here, psychology's here, endocrine care's here. I want someone who's going to think and formulate this all as one child or one patient and be able to then help me prioritize and really think about what's going to be best for my child. And so this is what we built, and we built it slowly, and I have an awesome team of professionals who work with us, and Susan Howell has been instrumental in making this all work and keeping families involved. And this was our first Extraordinary Kids Clinic. And it also became very clear that families really wanted more research, really wanted education of professionals and of new doctors, and really needed, ongoing support and advocacy. So this is our Extraordinary Kids Clinic program, and it's been, a lot of years and a lot of work in building it. And I feel like it's been a really helpful resource to a lot of families. However, there's no way we can see all families, even who are diagnosed. And with this upcoming, surge of infants that we really feel are going to be coming out, we definitely can't serve all of those. And then we're also not the best people to serve everybody everywhere, right? We know our Colorado resources, our regional resources, but when I need to refer someone to a psychologist or talk to a school system, if I'm talking to someone in New York, they say, who is this doctor from Colorado? And why is she telling us, what the recommendations are? And so people really need to be able to access care in their own areas. And, AXYS saw this as a true need, right? This is, the clinic is great and it's good that it exists, but, we really need to be able to provide more options to our patient or our members to be able to, do this. And so, and it wasn't only us. I mean, there definitely were other professionals who were specialized in Klinefelter syndrome and doing research and really good care around the United States at the same time, yet the kind of integrated approach was not as extensive as the clinic here. And so I think, when we're talking about what are the, big advances in terms of what's happened over the past couple of years, I really feel that AXYS has made a huge step in the creation and support of something that's called the ACRC, the AXYS Clinic and Research Consortium. And basically, AXYS has recruited some of and all of these professionals who were doing some of this work, as well as new professionals who were interested to develop a whole network of clinics for families to access. And there are now clinics in Colorado, here at Nemours with Judy Ross, and Emory with Sharon and Amy, Johns Hopkins, Cedars, Stanford. So we had a meeting yesterday of all of these clinics. Yay! And I just want to emphasize in in that meeting, there were many, many, many specialties that were involved in genetics and developmental peds and endocrinology and adults and adult care, which is a big new emphasis in terms of AXYS and trying to identify now more clinics and places where adults can go to receive care. In the past, Johns Hopkins was the only one, and so we need to definitely expand that. Urology and fertility, psychiatry, neurology, psychology. So lots of specialties in that meeting yesterday. And then all ages of providers, from trainees all the way up to old, experienced people who've been doing it for many years, which is so important, right? To have the young group that really wants to be excited about working with these to get and learn from the older professionals. Lots of expertise in XY disorders, and lots of expertise in other disorders. And so modeling and being able to know what other conditions have done and how other conditions have worked is also so important, right? Because we really need to learn from the experiences of other groups too. So this is going to be really important in advancing care for everybody and advancing research. Okay, so now we've got through that arrow, right? And so now we're going to talk a little bit about treatments. And this is where, there are unfortunately not a lot of advances in treatment, right? We have a lot of work to do to understand how to improve treatments. And treatment is not just medical care. It's education and educational approaches and supports. It's vocational supports. It's mental health care. It's family supports. And it's help in terms of connecting people with government and community programs and support. So there's a lot here to treatment, right? And this needs to be the next direction, right? We know, and we are learning a lot more about what we need to do, but being able to use and do this for the X and Y variations and do it specifically to be able to really, get the best bang for the buck in terms of what we're doing is really important. The next little arrow down here, that is the arrow that's going back, is this process really of improving all of this, right? And so that arrow is many, many, many things also, right? So this arrow involves the clinicians, involves us figuring out, well, what treatments work in what situations. It definitely involved the researchers, and there is a lot of really good basic and translational science that's going on in terms of neuroimaging and animal models and a lot of the basic pathways that are disrupted or changed when there's extra X and Y chromosomes. And so that piece is really going to drive also a lot of these next steps in terms of determining treatments and identifying different predictors of good and bad outcomes and other things. Patients and families and support and advocacy, all of this is in there because it's so important in guiding what those next directions and next steps in research are. How do we improve the clinics? How do we improve research? What are the important questions? And so all of these pieces are very important, and then clearly funding is important too. Any healthcare, medical support, family systems, all of it to improve it, the funding has to be there. So what are some of the important research questions, from our clinic and our perspective? There definitely are going to be great presentations throughout the conference from other professionals who are involved in research. And so you'll hear a lot of those researchers present to a family audience. You guys are also welcome. There's a research series where I felt like, we also want our researchers to be collaborating and talking to each other and developing ideas together and learning from each other. So you'll see in your program also a professional series. Families are welcome to come to that, and here we're just going to be giving little blurbs of different aspects of our research projects to each other with time for discussion as well. And I just want to let you know, when you come, those are going to be probably presented in a more scientific format compared to a more family-friendly format, but you're definitely welcome to come and ask questions as well in that series. That's the one that's not in Snowmass anymore, but moved to, yeah. You got it. So, the biggest questions we get from families when they come to our clinic are, how am I going to know, especially with our prenatal families, and we have a lot of families that now we're following who are these little infants, and, well, they're already kind of starting to grow up, and they want to know what predicts a good and bad outcome. How can I help my child do the best that they can be? And then, that goes for a postnatal diagnosis or an adolescent or adult too. What can I do to help him or her? And those are the biggest questions. And so there's a lot of different approaches, right, to that question. But one of the approaches is really understanding what the natural history is. And so I'm really excited to announce funding that we received for a new study that we're going to call the Extraordinary Baby Study. And this is a study that is to really help define and understand that natural history of kids with X and Y variations from infancy, and look at all of the different predictors of different outcomes. So we know there's increased risk for learning disabilities, there's increased risk for social difficulties, there's increased risk for medical issues such as type 2 diabetes or other medical problems. And what are the factors from early on that lead and help contribute to those or predict, what those outcomes might be. And so this study is going to look at many different early social markers of eye tracking and, different language patterns. It's going to look at motor pattern. It's going to look at all the hormones and hormonal profiles across all the different conditions. It's going to look at genetics. And we're going to really follow babies prospectively and follow over time then what happens as they grow up. And so this is really exciting, and we're so excited about being able to announce it. So it will be a natural history study. We're going to have prenatally diagnosed infants from 2 months to 5 years of age and follow them periodically. We're going to see you at 2 months. We're going to see you at 6 months. We're going to see you at a year, at 18 months, at 2 years, at 3 years, and really follow those trajectories of development over time. It's going to happen here in Colorado. There's also going to be a site with Dr. Judy Ross in Philadelphia and Delaware, and it's funded by the NIH. So that means it's your taxpayer dollars that are funding this, which is really cool too, right? Because I think a lot of families, why aren't we, there's no research on this, and it's so frustrating that no one knows about this. And so, I think this is one thing when you look at your paycheck and you see all that money taken out for taxes, you can know this is going to end up, being an over $3 million grant by the time the funding all finishes over the 5 years. And so that's a lot of money. It's also a good reason to remember, I don't want to get political, but we need funding for the NIH. So all these budget cuts that say no funding to research, don't vote for those. This is the big model, and I'm not going to go through all of it, but the idea in this first grant, in a 5-year period, you can only study kids for a certain amount of time. So our first grant really looks at kids until they're, 3 to 5 years of age. And we're really looking at outcomes in early childhood. But the idea is that this is going to go on for a long time until I retire and watch and see these babies grow up over time, right? And so see, what are the predictors of outcomes not only in early childhood, but also at school age and adolescence and adulthood, and tell us in adults what predicts adaptive functioning or life skills and occupational success and quality of life and relationships and mental health and, ovarian or testicular function, sexual health, fertility, all these other aspects of health. How can we predict that, and what do we know about the life course of these conditions? The other reason that these types of studies are important is because if you're designing an intervention for something, you need to know what the natural history is to know if that intervention works, right? Many of you have been in situations where, you should do this, you should try this vitamin, you should try this intervention program, you should try this form of testosterone, you should try and do it at this time or that time. And it's really hard to know if something works if you don't know what's supposed to happen naturally in life and development, right? For a speech intervention, for example, speech is going to develop in kids. You're going to see a trajectory of speech development in children. So if you do something along the way and you say, look, his speech is developing, well, it's going to happen anyway. So how do you know it's any different and really a true, helpful intervention to spend time and money on if you don't know that it's actually helping? So there's definitely trials and ways you can do this, but it's also really important to know what the natural history is. So if this, for example, was the natural history of speech development in Klinefelter syndrome, and then you did a study and you saw that it changed it to this trajectory, then this would be really important, right? And so this slide I think I stole is Liz here from one of my colleagues, Liz Berry-Kravis, but I think it's just really important to show why natural history studies are important, because it's really important to know, when we do interventions, if there's really a difference in that trajectory. So we're going to use the strengths of all the awesome artists that happen to be in the X and Y chromosome variation community. One area of strength, if you guys haven't seen, is many of these kids and adults have awesome skills in art. So you guys are going to be in charge of designing. We're going to have a contest for the logo of the study. And we're going to have you guys design it and then have that be the logo going forward. Isn't that cool? So the last piece is, in terms of big picture, is this big piece up here, right? The family. The patient, whichever person in this, in this group is the patient, their parents, their siblings, their extended family members, their spouses, all of that is really important in terms of this whole process, right? We wouldn't do this if it weren't for patients and families, but the idea of patients and families being involved in this process of research is actually fairly new. And I will say that Sharron Close, who is coming next, has been very revolutionary in applying and using patient-centered research methods and really investigating this in this population to advance research. And she's going to talk a lot about her project and her experience with this in terms of the X and Y variation group. But I have to say that this is, another, when I think of what are the big things and the important things in this field, Sharron's work and her dedication and motivation to really involving patients and families in this process is one of the biggest deals, because it's so important to hear your input to really, move things forward based on with your ideas and your participation and your energy. And there's a lot of positive changes coming, and so I'm really excited and honored to introduce Sharron to come and talk about this.
Good morning, everybody. It is so fabulous for me to look out and to actually see you. I hear you all the time online. I hear you in your Facebook. I listen to everything, but to actually see your faces is quite moving to me. And I must tell you that I've never given a keynote. I learned this from my student, Amy Bloomling. I've never given a keynote before. I'm a little nervous. Can I have a, oh yeah? Oh, yeah. Thank you so much. Thank you so much. So I'm going to be delivering a lot of background that combines I think, motivation that leads to what we're talking about, what Dr. Tartaglia just put together in terms of movement, hope, and trust. I didn't know that she just started in 2004. That's amazing to me because I came into the field at 2006. We talk about, well, why isn't there more research done? Why don't we know more? Well, the truth is, Klinefelter syndrome was just discovered in 1942, and then we understood the chromosomal reason associated with it in 1959. So it's not like we've known about this for centuries. We're really on the early stages of understanding this. So that's why we don't have hordes of research. But there's a lot of good things coming along that go with research. So what I have learned is that the depth and the breadth of this experience is of having or caring for someone with X and Y chromosome variations is extremely deep. I've heard from you in my studies in the past couple of years with, and I'll be explaining the study in a second, I hear a lot about uncertainty, frustration, confusion, anger, stress, and the cost of well-being. And this I found very powerfully stated. I kind of borrowed it from a philosopher. His name is D. Micah Hester. He's from Stritch University, and he says, the more threatening the experience, and I inserted, of dealing with X and Y chromosome issues for the patient, the more it tears at the fabric of this person's life. And conversely, the more issues with X and Y variation tears at the fabric of our relationships, the more severely it's experienced. And so the more we don't know, the more we suffer. And that's kind of where I live. I want to understand the suffering so that we can initiate interventions to help mitigate some of that suffering. So 2 years ago, I led a project funded by the Patient-Centered Outcome Research Institute, and it was called Bidirectional Translation of Knowledge and Need in Sex Chromosome Variations. Long title. But the whole concept was I wanted to get patients and families, clinicians and scientists together to ask what is important, what should we be focusing our research upon? So I thought in the beginning that I understood patient-centeredness. If I have a research study, I decide the research question, I decide that if I measure your quality of life or if I measure your symptoms, then that's patient-centered. But I learned something quite different over the 2 years that we conducted this study. I learned that patient-centeredness is about research coming from the patient derivation. You all experience the symptoms and the problems, and you all are very, very close to possibly contributing to the solutions. So why should there be researchers out here trying to study you when really the research could actually be coming from you? That's a pretty revolutionary concept. So the questions here are, can patients drive the science? And the other is, will researchers be open to patient-derived questions and patient-derived research? I found in the first year of this study some pushback from scientists who listened to the patient suggestions about what should be studied, and we often would hear, well, you can't study that. You know, researchers, we think in a certain way, and I'll be describing some of my early research that caused me to think very narrowly, but this experience with the bidirectional translation absolutely transformed the way in which I think research needs to be done. So a lot of things can't be solved in research, and some of the top things that came out of 2 conferences that we did during this project between 2015 and 2016 was that we need more awareness. We need to address the stigma issue. This came up yesterday in the ACRC meeting, why people don't seek help, why people don't tell others. What we hear from patients is, nobody knows about this. But then they say, I don't want anybody to know about this. I don't want my child's school to know about it. I don't want my neighbors to know about it. I don't want my mother-in-law to know about it. And then, of course, the patients we hear all the time, why is it that I have to teach the doctors what this is and what to do? So awareness, stigma, and education are very, very important to you. we heard this and we want to act on this, but it's not something necessarily that we can address by research. However, we can address it in some other ways. So awareness was the #1 issue that was cited by you all, by patients and families. And without awareness, we have barriers to health care. We have barriers to educational support. We have barriers to legal and disability concerns. And it is the most protected thing when we withhold diagnosis and knowledge about our stories, whether it's an X and Y chromosome variation or anything else. This creates a barrier because you're pretending that something is wrong and it can't be. It's not that you're pretending, it's that you're withholding it so that people can't then act on it. So we find that up close and personal, when you dig deep, stigma is really, really difficult. And it's something that we need to figure a way collectively to address and get past so that we can take these barriers down and, I guess, potentiate the opportunities for clinical access and also research. So stigma places these barriers on communication. How can you communicate with the school if they don't understand that there is a genetic basis possibly for your child having some learning disabilities or speech and language problems? Stigma with access, I've had patients before who were prenatally diagnosed and decided not even to tell their own pediatrician that their child had this, hoping that the pediatrician would figure it out along the way. That's pretty much of a barrier to access to care. Stigma also prevents us from talking about awareness. Why don't we have a Tom Cruise or a famous person up saying, I have a cousin with an X and Y variation? Because it's so stigmatized, people don't want to come forward. And then stigma withholds this understanding. It's a barrier in the pathway to really explain what this is about. So this is kind of an aside, but you often think, like, what's in a name? That which we call a rose by any other name would smell as sweet. So Romeo would, were he not Romeo called, retain that dear perfection which he owes without that title. I was Juliet in my college. Sorry, I just had to keep going. But anyway, so what do we call this? Sex chromosome aneuploidy. That's kind of scary. You know, aneuploidy, ooh, we don't know about that. And then sex chromosome variation. And then we have we call them syndromes, Klinefelter syndrome, Jacobs syndrome. Trisomy X doesn't have a person's name after it. And then parents are very sensitive to, are these disorders? Are they anomalies? Are they syndromes? Are they conditions? You don't want any of those names, am I right? I just want to call it a variation. But we have to be careful because the more we sanitize that to normalize it into common vernacular, then we fail to make the case for the needs. So if you go to the school and say, it's no big deal, my child just has this variation, then we don't make the case for why it's really important to insert these educational interventions or the needs. So we have to come up, yes? We have to come up with a collective way, and it has to come from you. It has to come from us. How are we going to stand on stigma and break it down so that we can call it something? So I have an idea. Ran it by Dr. T. I often get told no. It's my favorite thing when people say no because I always find a way. So patient-centered stigma busting, okay? That's the #2 thing. Awareness was #1, stigma busting was #2. We have to make it less sexy. People are so concerned about, oh my God, that means that he has girl parts and boy parts, or oh my God, that's the reason for sexual attraction or orientation. We have to be able to take the sexy part out of it so that we can focus on what it really is. So genetic descriptions now are going in a slightly different way. For example, formerly a syndrome that involves craniofacial, facial, and cardiac problems on a child is on the 22nd chromosome on the Q arm at the address 11.2. So if I say 22Q 11.2, a geneticist would know the address of that autosome and what the syndrome is. So you don't have to call it a syndrome. Down syndrome is often referred to as trisomy 21. So I'm thinking, why can't we evolve the name and the description of what it was we had? So genetics itself is moving away from the syndrome things, and it's easier to understand if you know the address. So here's just an idea. Why don't we call X and Y variations what exactly they are? Variations on the 23rd pair of chromosomes. It could be called 23V in any notation. And examples would be, you can see down here, the 47XXY, that's pretty far away from me, could be X2Y, meaning that you have two X chromosomes and a Y. If you have XXYY, it could be X2Y2. So it's descriptive, the word sex isn't in it, and it communicates exactly what's happening on that 23rd pair of chromosomes. Nicole talked about how convincing geneticists that this would be important, because doctors and researchers like to have control of everything. But having learned from patient-centeredness, I see no reason why a movement from the X and Y community can't evolve a new terminology that is the way you want it, not the convention. So, take...
There's one more consideration, because the SCA is sometimes called aneuploidy, and it's also called abnormality.
Yes.
1 out of 400, that ain't so abnormal.
Right. It's not rare. It's definitely not rare. So it's uncomfortable, I think, and that's what contributes to our inability to travel the path of awareness, because we're holding on to that stigma. So from the inside, from patients and families, we have to bust down that stigma. So call it what you want, but it's just an idea. Convincing the world, I think an editorial piece might be a good way of expressing this. But anyway, so we need to take charge of what is important to us by the narrative. The narrative meaning your story can be very, very powerful. Your story can actually mitigate some of this awareness and stigma in education. You can tell your story the way in which you want it to be told. So the narrative is a very powerful personal story. I have been a student of Rita Sharron at Columbia University, and I'm creating an elective at my university about this. But she says, in the telling of stories, we grow to know who we are and we become who we are. So we don't have to hide behind anything. If you're really candid and honest about yourself, then your true personal story, your true personal narrative can be honestly told in the world. So we have lots of ways in which we tell stories. Some of them are myths and legends. Fables are some of my favorites. We have family oral history. I know my oral history from French Canadian, and then the English people came over. I know my own family history. I know my community history. I live in a community that was once settled by the Algonquin Indians in New York, so I have my community history. And then we go to school and we learn geopolitical history and American history and world history, etc. Sacred texts also tell us about the condition of being human from thousands of years ago all the way through. But it's often fun to learn or hear stories in the novels that we read, in the poetry that we read, and also in lyrics of songs and song titles. So sometimes I'm very, very moved by the lyrics of a song. You go back and you listen to it over and over again, and sometimes you're very moved by a title of a song, and I want to share one of my very favorites. If I can't be number one in your life, then number two on you. It just gets me every time. It communicates exactly how I feel. And then the very next one will, get out your Kleenex. She got the ring and I got the finger. It's a very, very sad story. So just in the lyrics, just in the title, you kind of have the story, right? Before the whole thing is actually told. So I have a story about you. I started in 2006. I was a research assistant with Eileen Fenoy, Dr. Eileen Fenoy, who's a pediatric endocrinologist at Columbia. I was introduced to the community of Klinefelter syndrome, and I was fairly outraged listening to parents and families talk about how they go to this doctor and that doctor, and they come back with a bag of stuff, and then they come back again the next year, and none of it has ever been put together. And so for my dissertation study, I wanted to describe the physical phenotype in childhood. I wanted to look at early cardiometabolic biomarkers that might predict heart problems in early adulthood. And then I also wanted to study psychosocial health. Way too ambitious for a dissertation, but I did it anyway. And in so doing, I was learning to become a scientist. Scientists are very, very particular about, or they should be, very particular about the ways things are done in terms of ethics, etc. I was very concerned. I was trained very well in the vulnerabilities of bias. You have to be very careful not to insert your personal interpretations on the data that's coming out. The data actually talks. I was looking at blood. I was measuring boys' parts. I was so intent on filling in the little Excel databases so that I could dump it into an SPSS file and do a wonderful statistic analysis on the data. But the whole time I was collecting this data, I was inviting boys between the ages of 8 and 18 and their families, and they wanted to tell me their stories. And I was so concerned about getting the measurements right and getting the surveys done. I was being that scientist, but my ear and my heart was drawn over to the stories that they were trying to tell me. And I realized at that time that that's the good stuff. That's where we're going to find more answers than however many things I measure. So we tell stories all the time in the form of histories. So we have medical histories, we have family histories, developmental, social histories, history of present illness. My headache started 4 days ago. So this is essentially how we present in the clinical setting. But we often don't tell our deep stories to anyone other than a good friend or someone else. We need to tell our bigger and deeper stories. And so that leads me to the importance of the personal narrative. Have you ever thought about just writing your story? Write it down, how you feel. Some people journal, which is just wonderful. But to have a good personal narrative, you not only have to have the storyteller, you have to have the story listener. And there has to be that interpretation in order to move something. It's also a co-validation of personal truths. It's like being honest with somebody. This is about me. I'm terrified standing in front of you. I'm just going to put it out there. So just being honest and being very candid with people that you're talking to helps you dig down deep into what your personal story really is. So once we know narratives, we can take actions on those. We can combine similar narratives together. We do this in qualitative methodologies and research, which I happen to be doing right now. There's power in the combined voices, all of your voices to direct how X and Y variations are to be understood in the public, medical, educational, and legal domains. Those are the areas that we really need to get the stories out. So the story I'm about to tell you, it all began with a story. On a Thursday night, it was late, I received a story, or a crisis call. I took a crisis call, shall I call it, from a woman whose sister has trisomy X. And she was calling specifically to ask me what I knew about it. We talked about how there was no adult research being done on trisomy X. Her sister was severely affected right now and having a lot of difficulties. So we talked some about the brain and about brain volumes and about neurotransmitters and about why medications may or may not work in that situation. And in this conversation, I talked about how over the past 2 years, that was one of the big things that came out. that we didn't have awareness. We don't have enough research going on for all the variations. And so I talked to her about the previous meeting, the PCORI conference, and how people had talked in that conference about the need to have a public service announcement or a commercial. And I said, really, a really good way to disseminate this would be to do a documentary film. And then there was silence. And, okay, the director's saying something different. Anyway, I'm about to introduce her. And she said, Sharron, I'm a documentary filmmaker. And so within a very short time, the documentary filmmaker came to Atlanta, and we actually sat there for 5 days and talked about how a combined collective narrative could be told in the form of a documentary film. And in addition to that, and this is Diane Steinkraus. I'm about to introduce her, and she will clarify the story that we just told. That was my recollection of it. So we started a project. We would like to develop a full-length documentary film. In order to apply for film grants, it's necessary to produce a 10-minute segment. It's almost like preliminary data for researchers. So we formed this 10-minute segment that goes along with our applications to major foundations so that the major foundations know that we know what we're doing. Diane Steinkraus, I'm going to introduce her in just one second, is a writer-producer. She is an Emmy award-winning writer-producer who has a sister with trisomy X. So she is a family member, she lives this, and she happens to know truly how to make a documentary film. So the idea is to put together this documentary film and then to parse out some of it to be used in teaching modules with targeted audience for medicine and psychology, for schools and educational systems, for law enforcement, and also for the judicial system. And this is how we hope that we can make major awareness and impact and also facilitate some of the things that are happening clinically across the country. So the process of this was we had an initial fundraising that was very successful. Diane is here doing some filming in the Denver area. We did some previously in Minnesota. She's been to DC. She has senators on board who want to be in this film and actually support it. So the entire film will probably cost in the neighborhood of $500,000 to $600,000 that we'll be applying for major grants for. And the production, it may take more than a year. I don't know, Diane, you can talk about that in a second. But the most important thing is that this has to be your story. This is a collaboration and collection of personal narratives that will be your story. So while she's attending the conference, she's also setting up some film opportunities she's going to tell us about in a second. But I just want to wrap up my short piece here by saying, from what Dr. Tartaglia talked about and the things that I talked about from my research with patient-centeredness, is that there is tremendous movement. It's early. Nicole's been doing it since 2004. I've been doing it since 2006. Many other researchers are on board, and it's kind of like a house of fire. We have ignition, so there is movement, and there is hope that your story is going to be told, and there is trust that eventually we will find answers. So that concludes my part. I'm going to end with a favorite quote by Kermit the Frog. Life's like a movie, write your own ending.